Thank you, Paul. Delighted to be here. Every 6 seconds in America, every single day, 365 days a year, a person gets injured at work. I'm talking about a normal, hardworking person that goes into the workplace, works hard to support their family, and is now injured and in pain. Beyond this disruption to their livelihood, chronic pain results in a severe blow to their quality of life. Living with that pain is untenable. However, being prescribed opiates is an answer that has its own perils. Using an opioid for just 5 days causes a sharp increase in the likelihood that a person will use the drug long term. For many people, it can lead to a lifetime of addiction. In the last decade or so, this is millions of us going from being respectable citizens to being dependent on these harsh substances. Meanwhile, in Silicon Valley, in these same 10 years or so, virtual reality as a technology has made great strides. We've made well-functioning headsets, we've improved the usability on them, we've dropped the cost so dramatically down that it is available for widespread use in our lives. These headsets can help us tap into content that create immersive experiences that transform our sense of reality. We could climb the Eiffel Tower, be on the sparkling beaches of Brisbane, almost feel the sand in the toes, and listen to a Nobel laureate at MIT, all from the comfort of our living room and all on the same day. What if there was a way to overlay the sensory hijacking technology onto chronic pain? The intersection of virtual reality and medicine has been studied quite extensively for years now. I have references on this screen from the year 2004. In the year 2018, Dr. Pramoda and his colleagues at University of California, Santa Cruz, did a meta-study on 28 other studies and concluded that non-pharmacological adjuncts like virtual reality have indeed become important options for effective pain management. The evidence presented in the review demonstrates the potential for virtual reality distraction therapy to provide effective analgesia for patients that struggle with varied forms of pain across multiple care settings. It supported the hypothesis that virtual reality can distract the patient, can reduce pain and anxiety, and can provide short-term relief for patients struggling with acute as well as chronic pain. They also found that virtual reality environments that were immersive and those that allowed the patients to interact with the content were among the most effective. Through all this research, VR as a technology has been proven to cut perceived pain by about half. The effect it has on the brain is to actively engage the brain in the processing of sound and visual stimuli and make the brain busy, such that now the brain is suppressing pain signals. Today, imaging technology has come very far. The yellow portion of these fMRI images depict the brain as it's experiencing pain sensation. Now, as you can see, experiencing virtual reality dramatically reduces the effects of pain in the image to the right. Pain has multiple dimensions. Each one of us perceive pain differently, and we experience pain differently. As we started exploring this, it became clear that as a disease state, chronic pain has its roots in 2 different disciplines of human science, biology and psychology. Challenges emanating from biological and psychological reasons are coexistent and intertwined in chronic patients. However, the weighting of these 2 factors varies considerably from patient to patient. Therefore, to solve the problem at a population health level, we needed a solution that had an analgesic component that would address biological issues like wounds, fractures, and crush injuries, and a behavioral health component to address anxiety, depression, and pain catastrophization. These two components need to be weighted differently when being delivered interventionally on a per-patient basis in order to achieve optimal benefit for each patient. Now think about how you combine this with virtual reality therapy. Now there is an additional benefit of being able to be customized on a per-patient basis. We can vary virtual experiences in which the patient is immersed during the session such that different content have different impacts on the patient experiencing them. These virtual experiences can be categorized as knowledge modules, distraction modules, meditation modules, and escape modules. Furthermore, this modality can be delivered in a patient's home, which is the ideal environment for treating a patient in pain. So with this as the program design about 2 years ago at Harvard MedTech, we started partnering with pain physicians around the country to support patients in chronic pain. The program contained a VR headset with personalized content, support from a behavioral health expert that partnered with the patient's physician. Nesting the behavioral health interventions within a medical program, in this case pain management, took some of the stigma out and allowed the behavioral health technician to leverage gait control theory to address pain signals amplified by previously untreated behavioral health issues. The immersive nature of the virtual reality therapy facilitated neuroplasticity for increased pain resilience. The combination of virtual reality therapy, behavioral health therapy, and the clinical oversight allowed patients to become more resilient. They learned to manage their pain, and their anxiety related to pain is now decreased. This enables patients to achieve their personal, physical, behavioral, and social goals. And here's the best part. Patients reported increased ability to walk, to complete their chores, participate socially, and return to work. By way of numbers, 102% increase in quality and duration of sleep, 297% in behavior-based goals, 349% increase in physical and mobility-based goals, and finally, 390% increase in social-based goals. So the virtual reality pain relief program is an example of neural rewiring. This is neuroplasticity and gait control theory at work. Repeated exposure to virtual reality content allows neuroplasticity to occur over time, and it enables the analgesic benefits of distraction to become hardwired. Also, an improved emotional state is achieved through a combination of exposure to the meditation content from VR and behavioral health interventions. So you put the two together, it results in increased pain resilience. It's unclear exactly what the neurobiological mechanisms are that make virtual reality effective. One often referenced theory is gait control theory of pain that was first proposed in 1965 by Ronald Melzack and Patrick Wall. The gait control theory of pain suggests that alternative stimuli can reduce the intensity of physical pain by blocking pain messages at the nerve gates of the spinal column. McCall and Mallet built on this idea by theorizing that humans have a limited amount of attention, and they must pay attention to a painful stimulus for it to be perceived as painful. On the topic of patients who are most likely to be successful with virtual reality, we think about them as three categories. Category A, newly injured patients. These are patients that may need some form of surgery and have chronic pain from injury. The opportunity that we have with these patients is get virtual reality therapy prescribed for pre- and post-surgery pain relief, and combine that with a minimal, say, 3-day supply of opioids to tide over acute pain from surgery. Our goal is that the patient emerges post-surgery without having developed an opioid addiction. Category 2, these are patients that got injured less than 7 years ago, and they are receiving some ongoing pain management treatment. A vast majority of these patients are addicted to opioids at this point, but the severity of the addiction varies. The opportunity we have with virtual reality programs prescribed for this pain management in lieu of opioids or in conjunction with reduced opioids. Our goal would be to wean these patients off the opioids or significantly reduce the amount of opioid usage. Category C, these are patients that were injured more than 7 years ago, receiving ongoing pain management treatment all this while. These patients are hard. A vast majority of these patients are addicted to opioids, and if addicted, the severity of their addiction is high. Unfortunately, these patients are not good candidates for virtual reality therapy. Their addiction levels are generally so severe, and their behavior patterns are so ingrained that virtual reality therapy is generally not going to be very helpful for them. These patients are candidates for alternative medications and more intensive treatments like inpatient rehab. Like everything in healthcare, this is a team sport. Today, we have a growing set of partners who are leaders in their own right, supporting this mission to improve patients' quality of life through a technology-aided tele-pain solutions. What's more, workers' compensation carriers from around the country have eagerly supported this with reimbursement as a way of getting patients back to the workplace quickly. It did take us a little bit of work through the right form of documentation that clarified the patient's need as well as our approach so that we could reduce the lead time to secure payer approval. With more experience, we were also able to dial up the approval rate. It's exciting because VR technology is evolving quickly, both on the hardware side and the software side. The ability to project the patient as an avatar, think about it as a participant in the VR experience. I'm talking about without needing the need for towers or external monitoring systems, holds a lot of promise. This could allow us the opportunity to capture and record movements of the patient while they're immersed in a VR experience, like range of motion, stability, and many other measures of functional restoration. It could turn out to be a home-based alternative to traditional physical therapy for certain class of patients. Some other areas we are currently looking into include insomnia, anxiety, and depression. I am optimistic. What this in summary means is that the answer to pain doesn't have to be solely in opioids. This combination of technology with clinical and behavioral health support is a viable way now to manage the condition of chronic pain. It's also a cost-effective way to approach the burden of pain. But above all, it's taught me that the answer to rewiring our perception of adversity is within us. I salute to the human potential in each one of you and in the potential of all of us as a collective. Let's join hands in improving the human condition. I look forward to hearing from you. Thank you. Back to you, Paul.